So my name is Abigail Johnston, and as we record this, I am sitting in Orlando, Florida. It's hard to think back, but it has been more than 20 years since I graduated from law school. I graduated from law school in 2002, and I've been a licensed attorney in Florida ever since then. I did a variety of things, different types of law during the time that I was practicing. A lot at the beginning was personal injury, so dealing with people who had car accidents or medical malpractice or some product hurt them, slip and falls, that sort of thing. Then over time, I transitioned into doing more family law. That all served me very well. When I was diagnosed with stage 4 metastatic breast cancer in 2017, and I like to call myself a professional patient at this point because basically I go to the doctor and that's my job, as well as taking care of my kids and that sort of thing. So going from going to the doctor maybe once a year to probably having a doctor's appointment with some specialist once a week, it seems like sometimes, that was a really big adjustment. And then dealing with all of the stuff that came with that on a personal level, I started seeing so many of the things that are broken in our system and how hard it is to access care. And that led me to start my own nonprofit, which is Connect for Legal Services. And what I do is I recruit lawyers to do pro bono work for people with stage 4 cancer. And I also run legal clinics. And so I started seeing a whole lot of trends in questions, trends in issues, and honestly, trends in solutions. As I began to talk to as many people who sign up for my monthly legal clinic that I do through Project Life, really, health insurance can be divided into two buckets, which is private and government. And that is having to do with which entity is paying, is actually writing the checks to pay for whatever medical treatment has happened. You can get a private policy. Most people get private policies through employment, whether your employment or your spouse's employment. When that's not a possibility, through the Affordable Care Act, there are health insurance companies that participate in the marketplace, but you can always go directly to a health insurance company and get a private plan, whether that's through the marketplace or not. The good thing about the marketplace is that there is structure in terms of what has to be covered. And then there are opportunities to get subsidies that usually depends on income. So the challenge for the marketplace generally is that every state is completely different. And some states will have one participating provider. Other states will have more, so there will be some more competition. But the marketplace can be complicated. So that's, private health insurance through employer, private health insurance either directly through the health insurance company or through the marketplace. For people who have left their employer, there is COBRA coverage typically, which is supposed to cover you for up to 18 months after you leave a position. Then we get into the government plans, which have a whole lot of different types of structure, right? Medicaid is usually the program that is offered to people who have, their income is what tied to the poverty level. So it's usually the poverty level times 100% or times 400% is usually how that is evaluated. But then you get to the point where Medicaid is both federal and state. Some states have expanded Medicaid, some states have not. That can be super complicated, and that is usually a place where you really need a social worker to help you figure out exactly what you qualify for, which programs you don't. And then we come to Medicare. So Medicaid is tied to income. Medicare you can access two different ways. You can access that through Social Security disability. So for people who have been diagnosed with a serious illness, there's a 5-month waiting period for Social Security disability. Once that 5-month waiting period has expired, then you have 24 months before you are eligible for Medicare. So if you've been diagnosed with a serious illness like metastatic breast cancer, you take your date of diagnosis, 5 months later, you're eligible for Social Security disability. And then so 5 plus 24, which is 29, if I can add correctly. Date of diagnosis, 29 months later, theoretically, you are eligible for Medicare. But you have to have applied for Social Security disability. You can't just sit around and wait. In order to qualify for Medicare, you need to apply for Social Security disability. Medicare has a whole lot of parts. Part A is the part that is offered for free once you're eligible for it, and that covers hospitalization. So the nice thing about that is that you can have Medicare Part A and private insurance at the same time, which is actually personally what I have. I have my private insurance through my husband, and then I have Medicare Part A. I go to the hospital, I pay zero, because Medicare covers whatever my private insurance doesn't cover. It's a very seamless process. It works great for me anyway. Once you get to B, and I think all the way to M, and they may be adding more parts of Medicare, the other parts cost money. And I always recommend to people who are transitioning to Medicare because of Social Security disability, or you can also get Medicare based on your age. 65, you start getting different types of benefits once you hit 65. Always sit down with a Medicare broker, because for those of us who are in the metastatic breast cancer community, our treatments, our medication, our doctors, our scans are all in the top tier. So the things that cost the most. And you may have heard of the donut hole, right? So a lot of people who went on Medicare and thought that they had coverage for medication realized that there was this hole, which is the most expensive drugs, were not covered, or not covered without a really significant out-of-pocket cost. And so I always recommend working with a broker, because this is what they do. They have you list your medications, they have you list your doctors, they have you list your scans, and then they back into the policy or the part or the supplemental plan, or whatever it's called, the thing that will cover you. Even to the point where I know some people where you will sign up for one thing for the first 6 months, and then you sign up for the second thing for the second 6 months, because there's different benefits to the different parts or the different supplements. The people who are insurance brokers who specialize in Medicare, they are paid by the plans, so you pay nothing out of pocket. And I believe are really key in designing coverage that will actually cover what you need to have covered. I believe all insurance brokers have to have a license. And so you can always Google insurance brokers in my area with your zip code. I typically recommend that you look for a broker that specializes in Medicare, advertises that they specialize in Medicare. And then I suggest you ask, how many people with metastatic breast cancer have you worked with? Because it really is a bit of a niche. I have some insurance brokers that I work with that I send the people with MBC to them, because I know that they have done the extra work to really understand metastatic breast cancer. So, and there are also brokers that specialize in the marketplace. So they would help you design or pick the right plan within the marketplace as well. So usually a Google search would give you somebody. I also always recommend that you ask the social workers at your cancer center, if there is one, or either that or nurse navigators, because a lot of times they've worked with people and developed relationships with brokers that have some kind of expertise or extra training or whatever there is. One other thing that can be a little bit complicated is that most pharmaceutical companies have they will have a foundation, and then they will have specialized copay assistance programs. Now, copay assistance programs are designed to help you with your copay, because we're in that top tier again, right? So even if you have an amazing health insurance policy, a lot of times you'll, based on the negotiations between the pharma companies and the health insurance company, you may end up in that top tier and have a significant copay. So if you have private insurance, the copay assistance programs can come in and defray that cost. Quite frankly, I think that's the least that they should do, because the amounts of money that are being paid out by health insurance companies are pretty significant. But pharmaceutical companies put a whole lot of time, effort, and money they expend that in order to develop the medications. And so the price points are set based on how much of that they had to put in. So when you have private insurance, you can have access to these copay assistance plans. In my experience, typically the pharmacist or the pharmacy where you get your medication filled can often help you apply for those things. Otherwise, it's a pretty easy process. The problem that many people encounter is when they are on either Medicaid or Medicare, you no longer qualify for those copay assistance programs. And the reason for that is how Medicare is able to negotiate with the pharmaceutical companies on behalf of everybody in Medicare. That means then that there are certain perks that are no longer offered because they've already negotiated as a good a rate as they can with the pharmaceutical companies. So at that point, some people will get a $2,500, $30, or $3,000 a month, $2,500 or $3,000 a month copay until they reach out-of-pocket maximums and those kinds of things. Regardless of what insurance company, policy, government, private, COBRA, whatever, regardless of what it is, the most important thing that people need to know about what they have is what it covers. And most insurance policies are going to be hundreds and hundreds of pages long. Typically, you can get that directly from the company, and typically they are searchable. So they are usually in PDF, and usually you can search for keywords. And there's a couple of key things that I think everybody should know. Number one is your deductible, right? That's the money that you have to pay every year before you hit your out-of-pocket maximum, before sometimes some benefits kick in. So that's the number one thing first. And realize there may be more than one deductible. So I have a deductible that applies to doctor's visits. I have a deductible that applies to medication. Different numbers. I have to meet both of those. I have to pay both of those things before my insurance kicks in. The second thing that's super important to know is your out-of-pocket maximum. So pretty much every plan I've seen, and I doubt there's plans that don't have this, but every plan says you have to pay up to X amount, and then the insurance kicks in either at a different level, different percentage, that sort of thing. So between your deductible and your out-of-pocket maximum, that's what you've got to plan to pay throughout the year before the insurance coverage typically kicks in at a higher percentage. Sometimes you can have what's called co-insurance in there too. That's usually hospital stuff or procedures. But your deductible and your out-of-pocket maximum are the two things that you really should know and have in your mind, because number one, you have to budget for that, right? And number two, it's really nice to be able to walk into a doctor's office and be like, nope, I've met my out-of-pocket maximum. I don't have a copay today. I don't have anything to pay. In addition to knowing kind of those big picture numbers, knowing other numbers like what kind of scans and how many will my insurance cover. So Medicare is the most restrictive. There's actually a lifetime limit on PET scans, which many cancer patients get. A PET scan is where you are injected with a radioactive isotope that reacts with metabolic activity. And because cancer is really, really active, you have things that light up, or you hope you don't have things that light up, but when you have cancer, things light up. And that can give a doctor a really good understanding of how active, metabolically active the cancer is. So if your doctor orders a PET scan, sometimes, and quite frankly, a lot of times, the insurance company will challenge that order by saying, is this really necessary? Now, every doctor's office I've dealt with, they know how to deal with that. They schedule a peer-to-peer where your doctor is talking to a doctor that's hired by the insurance company. But here's something really important. Your plan says what you are entitled to in terms of that peer-to-peer discussion. What's a peer? Well, let me tell you, the first peer-to-peer conversation that my medical oncologist, who had 30 plus years of experience, she was talking to somebody who is a family medicine doctor who had been out of medical school like 5 or 6 years. Are those peers? I don't think so. And I objected and was able to have my doctor, unfortunately, she had to do the peer-to-peer at the second time, but they actually provided an oncologist with a similar level of experience. That, as a person who is paying the premiums, typically that is in your policy, and you are entitled to have the insurance company paid for a peer to talk to your doctor. In my experience, in dealing with a lot of these, and my own personal experience, when an oncologist is talking to another oncologist, things don't get denied as frequently. When your oncologist is talking to a family medicine doctor or a podiatrist or an ophthalmologist, somebody who has a specialty that's different from oncology, number one, there's a huge amount of education that has to happen there that your doctor shouldn't have to. Your doctor should not have to spend the time justifying their treatment plan. They should be able to talk to somebody who understands what they're talking about. That is different from, if you're trying to do something experimental, right? But at a basic level, you are entitled for your doctor to be able to talk to a peer. Typically, when an insurance company denies something that is standard of care or is typically done, that's it. They have the peer-to-peer discussion and it is approved and it goes forward. If it doesn't, then there are other things that have to happen. Many insurance companies, before they will pay for a PET scan, will require a bone scan and a CT scan. So a bone scan, again, you're ingesting some kind of radioactive tracer that reacts with different things in your bones differently, so that the cancer, instead of lighting up on the scan, it shows up as black. And sometimes MRIs then are ordered to look at the organs more carefully. Here's the thing that I've heard from doctors. Doctors like different scans. They like looking at different scans. They like comparing different scans. If you've always had one kind of scan, they like to look at that other kind of scan. Your doctor is going to be the one to know what scan they need in order to see what they need to see. And they will work with your insurance company the best they can to get the images that they need in order to make good decisions. I know that some people get really, really, really upset when they can't get a PET scan, whether it's because they have Medicare or their insurance won't cover it or whatever. Doctors know how to deal with this. And whereas some doctors think the PET scans are the gold standard, are everything, they also can work from a CT scan and a bone scan. So the biggest thing with this is not to worry as a patient, that the doctor is going to do what they need to do in order to get you the care that you need, in order to get the scans that they need. Yes, insurance companies are a bit of a gatekeeper when it comes to this, but if it's really necessary, your doctor knows how to get things covered, or their office does, right? Sometimes it's not the doctor in particular.